Hi everyone. In this class, we'll continue with the another class of anti-hypertensive. So here, those are RAS inhibitors, RAS system inhibitors. So RAS system is the important system in the regulation of blood pressure as well as in the water homeostasis in the body, fluid homeostasis in the body. So that's why these drugs that inhibit this RAS system becomes the cornerstone drugs for treating the hypertension. So here how this RAS system is activated whenever the sympathetic system is overactive or whenever the sympathetic system is activated, so which can stimulates the beta 1 receptors in the kidney, juxtaglomerular cells of the kidney, and causes the release of renin. Apart from this, so whenever the fluid volume and whenever the sodium concentration is low, whenever the blood pressure falls, so these all are causes the release of renin from the juxtaglomerular cells of the kidney. So what this renin do? Renin is actually the enzyme. Okay, what it do? Which converts the angiotensinogen that is released from the liver into the angiotensin 1. Okay, so this angiotensin 1 is the inactive form, inactive peptide, and which is further converted into the angiotensin 2. So this angiotensin 2 conversion of angiotensin 1 to the angiotensin 2 is inhibited by the angiotensin converting enzyme. So then, so the angiotensin 2 that is produced from angiotensin 1 can elicit its effects by acting on corresponding receptors on various targets. So those are what? Angiotensin type 1 receptors and angiotensin type 2 receptors. So what are the target organs for the angiotensin 2? So those are blood vessels and adrenal cortex and CNS. Okay, so and then directly acts on the renal tubules of the kidney. Okay, what it do? So which causes vasoconstriction and which causes the release of antidiuretic hormone and increases the thirst, water intake, and which causes the release of aldosterone from the adrenal cortex. So what all these will do? Here vasoconstriction, they increases the BP by increasing the total peripheral resistance. Okay, and then aldosterone secretion may increases the fluid and water retention into the body. Okay, so thereby the blood volume is increased, so thereby the blood pressure is increased. So antidiuretic hormone, so water retention, which causes water retention. So in all these may contribute to the rise in BP. Okay, so that's why, so when we block this system, the blood pressure may control, we can control the higher blood pressure. So here various drugs acts at various levels of the RAS system. So here first category of the drugs are the renin inhibitors. So where they act, here they block the effects of the renin. They binds to the catalytic site of the renin. They binds to the catalytic site of the renin. Which is the example for renin inhibitors? Aliskiren is the example for the renin inhibitor. So how it acts? So it acts by binding to the catalytic site of the renin. So that's why what happened? So which prevents the association of renin with the angiotensinogen. So thereby what happened? So renin unable to convert the angiotensin 1 to the angiotensin 2. Angiotensinogen to the angiotensin 1. Okay. So thereby the further steps is also inhibited and the aldosterone release and is inhibited, vasodilation may take place, and antidiuretic hormone release may inhibited. So this can all contribute to the fall in BP. Okay, so these are the first category of drugs. So here then the next important category of the RAS inhibitors are the angiotensin converting enzyme inhibitors. So where the acts? So here the angiotensin converting enzyme is one of the rate limiting enzyme. So in the production of angiotensin 2. Okay. So when we inhibit this enzyme, angiotensin 1 is not converted into the angiotensin 2. So thereby what are the examples for these drugs? Enalapril, captopril, ramipril. These are the some of the examples for the ACE inhibitors. These are also one of the important drugs. So how they act? They act by preventing the conversion of angiotensin 1 to the angiotensin 2. So without angiotensin 2, it unable to act on the target site, it unable to produce its effects. So thereby what happened? So vasodilation of blood vessels may take place, both the arteries and veins. So this will dilation of arteries may causes the decreased total peripheral resistance. Resistance to the blood flow is decreased, so thereby pressure on the artery wall is also reduced, and which also dilates the vein. Minimal effects on the vein, so this can decreases the venous return to the heart because of escape of fluid, then which can decreases the cardiac output and decreases the fall in BP, and other which also decreases the aldosterone release and ADH release. So thereby, so it unable to cause the sodium and water retention, and thereby it decreases the fluid volume. In that way also it can decreases the cardiac output, and it may responsible for the fall in BP. Okay, so these are the effects of angiotensin. How angiotensin converting enzyme inhibitors are helpful in treating the hypertension. So one of the important factor in the angiotensin converting enzyme inhibitor is, so here angiotensin converting enzyme inhibitors, angiotensin converting enzyme, so which is not only, it is a non-selective enzyme which is not only responsible for the conversion of angiotensin 1 to the angiotensin 2, so which is also responsible for the breakdown of bradykinin in the body, and which is also responsible for the breakdown of substance P, and which is also responsible for the breakdown of stem cell regulatory peptide. So apart from inhibiting the production of angiotensin 2, bradykinin levels also elevated in the body, substance P levels also elevated in the body, stem cell regulatory peptide levels also elevated in the body. So this bradykinin and substance P elevation may contribute to the side effects such as cough, which also cause vasodilation, but so it's short lasting. Okay, so then it may contribute to the dry persistent cough, and which is also responsible for the angioedema. And this increased stem cell regulatory peptide may contribute for the cardioprotective actions of the angiotensin converting enzyme inhibitors. So let's discuss the side effects. Okay, so here it can cause fall in BP, initial fall in BP. Apart from that, uh, first dose, initial dose hypotension is seen with the angiotensin converting enzyme inhibitors. Along with that, so it can also cause hyperkalemia. How it cause hyperkalemia? So here it inhibiting the aldosterone. Aldosterone release is inhibited from the adrenal cortex. So then what happened? Without aldosterone, the sodium channels and potassium channels are not activated in the collecting ducts. So then sodium reabsorption does not take place. At the same time, potassium secretion does not takes place. So that's why the water and sodium reabsorption is inhibited. At the same time, potassium secretion into the renal tubule is also inhibited. So thereby what happened? Sodium is retained within the renal tubule itself, and potassium is retained within the body itself. So that's why it can causes the hyperkalemia. Okay, so apart from this, so here which can also causes renal failure in the bilateral stenosis patients, and which can also causes the which can also fetopathic, which can also teratogenic to the pregnant women. And apart from this, which can cause cough because of elevation of bradykinin levels, and it can also causes the angioedema because of elevation of bradykinin levels. So these are the side effects of the angiotensin converting enzyme inhibitors. Let's see. So here side effects of ACE inhibitors is, one is cough, and one is the hypotension and hyperkalemia, angioedema. One more is dysphagia, but that is present only with the captopril, not with the other drugs. Okay, and headache, GI upset, acute renal failure, fetopathic, and one more is granulocytopenia. So these are the side effects. So these drugs should not be given with others. Possible drug interactions with these inhibitors includes diuretics. They both causes the fall in BP. Okay, so when we use in combination, this synergetically increases the fall in BP, and here it causes the hyperkalemia because of the inhibition of release of aldosterone from the adrenal cortex. So here when it is given along with the potassium supplement or potassium sparing diuretics, so further increasing the potassium concentration in the body, which can lead to a higher risk of hyperkalemia. And NSAIDs, what they do, they causes the sodium and water retention. So here what we are doing with ACE inhibitors, we are blocking the sodium and water retention. So when we use these two drugs in combination, the fall in BP is opposed by the NSAIDs. Along with that, so antacids can decreases the bioavailability of the ACE inhibitors, and lithium levels are increased by the ACE inhibitors. These are the drug interactions of the angiotensin converting enzyme inhibitors. Okay, so then coming to the uses, so these are used for the hypertension, myocardial infarction, congestive heart failure, nephropathy. Either it is due to diabetic nephropathy or non-diabetic nephropathy. So in both, in the renal failure, in both cases we can use these drugs, and along with the scleroderma crisis. Okay. So then for not only for the ACE inhibitors, for the direct renin inhibitors, for the ARBs, these are the same indication, these are the same side effects, and these are the same uses, but they differ in some points only. For example, when coming to the angiotensin receptor blockers, so how they act by preventing the effects of angiotensin 2 on their target sites by blocking the angiotensin type 1 receptors on their target sites. Okay, so on the target sites, on the blood vessels, on the adrenal cortex, receptors are blocked, so thereby ultimately the angiotensin 2 effects are blocked. So what are those? Vasoconstriction is blocked, aldosterone release is blocked, thirst is blocked, ADH release is blocked, central sympathetic activation is blocked. So thereby it can lead to the fall in BP. Okay, so then here some differences between the angiotensin converting enzyme inhibitors and angiotensin receptor blockers are, so here in case of angiotensin converting enzyme inhibitors, angiotensin converting enzyme is angiotensin 2 production is not only mediated through the angiotensin converting enzyme. So when we block the angiotensin converting enzyme, so angiotensin 2 production is not entirely blocked. Okay, so here it can also, angiotensin 2 is also produced through other other enzymes. Okay, so those are chymase, cathepsin, and tissue plasminogen activators. So these are also responsible for the production of angiotensin 2. Okay, then if feedback increase in the angiotensin production may takes place. But in case of angiotensin 2 receptor, angiotensin type 1 receptor blockers, ARBs, so when the angiotensin 2 is produced by the alternate pathways, also unable to stimulate the angiotensin type 1 receptors, because where the receptors are completely blocked. So how much it is independent of how much angiotensin 2 is present in the body. Okay, so but one more drawback for the angiotensin 2 receptor, angiotensin receptor blockers is, so when the angiotensin 2 levels are increased, so this angiotensin 2 can able to stimulate the angiotensin type 2 receptors instead of angiotensin type 1 receptors. Okay, and here there is no cuff because of the it unable to inhibit the bradykinin. We are not inhibiting the ACE inhibitors, thereby the bradykinin levels are not elevated here. Okay, so these are the differences between the angiotensin receptor blockers and angiotensin converting enzyme inhibitors. Remaining everything is same. Okay, so the last and final category are the renin inhibitors. How they act? They act by binding to the catalytic site of the renin, so thereby they prevent the association of angiotensinogen with the angiotensin renin. So thereby what happened? So renin unable to convert angiotensinogen to the angiotensin 1. Okay, so thereby the following steps in the RAS system is also inhibited. Okay, so then, so now renin inhibitors are only currently used for the treatment of hypertension. So some trials have been done for treating congestive heart failure, myocardial infarction, but not yet used. So these are now it is used, it is using as an alternate drug to the first line drugs when tolerance is developed to the first line drugs, or some are intolerant to the drugs. So in that cases we can use these renin inhibitors. Okay, this is regarding the angiotensin RAS inhibitors. What are those? Direct renin inhibitors. Side effects are mostly same. Here also angioedema, here also hyperkalemia, here also uh, here also GA disturbances. Okay, here also headache, dizziness, and these are also not suitable for the pregnant women. Okay.